Hi, my name is Julian Hong, and I'm a radiation oncologist at UCSF. Thank you for the opportunity to present our work. Today, I'll be presenting a study that was performed at my former institution, Duke University, entitled A System for High Intensity Evaluation During Radiation Therapy, or SHIELD-RT. It is a prospective randomized study of machine learning directed clinical evaluations during outpatient cancer radiation and chemoradiation. These are our disclosures. We do have a pending patent on the content of this study, but the code is open source and freely available online. About 650,000 patients with cancer in the United States will receive either radiation therapy or systemic therapy in the form of chemotherapy, immunotherapy, or targeted therapies. Among these patients, roughly 10 to 20% of outpatient courses of radiation or combined chemoradiation will require acute care visits, either in the form of an ER visit or a hospital admission. This has become a priority for high quality cancer care, as well as for CMS. And during radiation therapy courses, which can last from one treatment in one session up to 9 weeks, radiation oncologists see patients every week to manage any potential side effects from treatment, symptoms from disease, or any other healthcare concerns during this period. Though randomized control studies are the gold standard for establishing clinical evidence, there remain few evaluating machine learning and its ability to improve clinical outcomes. Thus, the objective of this prospective randomized study was to determine whether or not machine learning could be used to direct mandatory supplemental twice-weekly evaluations to reduce acute care during courses of outpatient radiation therapy or chemoradiation. We previously published our machine learning model based on 8,000 outpatient external beam radiation courses. This model utilized pre-treatment electronic health record data, which was populated from an internal system called Deduce, which aggregates data from the clinical data warehouse. This data includes elements of the medical history, social history, medications, laboratory results, vital signs, and we additionally included elements of the oncology treatment plan. These data were then synthesized, and 6,107 radiation courses were then used to train a machine learning model that was based on XGBoost, and subsequently validated on roughly 2,000 radiation courses. And retrospectively, we had a model with an AUC of 0.798. And at the cutoff that we selected had a good sensitivity and specificity compared to other previously published models for a fairly challenging problem to predict. The goal of this study, though, was to generate high quality predictions and then use those predictions to direct an interventional strategy. This is the schema for our randomized study. During the course of this study, all adults with any cancer type that were treated in the Duke Department of Radiation Oncology were screened with close to 1,000 patients. Each patient underwent a week 1 machine learning assessment of their electronic health record data. And high-risk patients were thus identified with machine learning. And we defined these patients as those with a greater than 10% risk of an acute care visit during their treatment course, which yielded 314 patients. And these patients were then subsequently randomized either to the standard of care, which consists of a once-weekly clinical evaluation with their treating radiation oncologist, or to a mandatory supplemental twice-weekly clinical evaluation, which consisted of an extra check during each week. The primary endpoint of this study was the acute care rate during the courses of treatment, and the study had an 80% power to detect a decrease from 20% to 10% acute care rates with a one-sided alpha of 0.05. This is the consort diagram for our study. 963 courses were evaluated during the course of the study. 361 were identified by machine learning as high risk. Among these 361 courses, 314 underwent randomization, and ultimately 157 patients were randomized to the control arm, consisting of once weekly evaluations, while 154 proceeded to be seen twice a week. These are the results of the primary endpoint for our study. During the course of the study period, 76 of the 963 courses, or roughly 8%, resulted in an acute care visit. Among those high-risk courses that underwent randomization, 22% of the control outpatient courses resulted in an acute care visit, and this was decreased down to roughly 12% in the interventional arm. One of the secondary endpoints of the study was to also investigate the 15 days following treatment because side effects can sometimes lag behind. And within this analysis, there's a similar effect from 32% down to 22%, which was also statistically significant. In addition to the results of the randomized component of the study, the low-risk courses, which did not undergo an intervention, were accurately triaged and had a lower than 3% rate of acute care. This is the ROC curve during the course of Shield RT, and for those patients who did not undergo any intervention, the AUC was 0.851. And this is our calibration plot, which demonstrates good calibration across patients who did not undergo an intervention. There are, of course, limitations to our study. It was implemented at a single institution, and so, of course, it's unclear how well it would generalize to other institutions. In particular, this is one element of clinical practice that can be fairly variable since supportive care resources can be different from institution to institution. The control arm by design was the standard of care, but one of the study designs that we had considered was randomizing all patients to either machine learning evaluation or not. With that study design, it would have required many more patients to sufficiently power the study, since, as you could see from the Shield RT results, the overall rate of acute care is fairly low. And then the mechanism for decreasing acute care is not well defined. We were able to show that twice weekly visits reduced the rate of acute care, but the exact reasons for this, whether it's reassurance, increased medical management, other supportive measures, those elements are not quite well defined. In conclusion, we were able to successfully execute a randomized controlled study showing that we can implement machine learning within the context of an existing healthcare practice and use it to direct an interventional strategy that improves clinical outcomes by decreasing acute care rates during outpatient cancer therapy. This is a priority in delivering high quality cancer care. And we have a number of ongoing and future studies. We are looking at a cost analysis of Shield RT. We're also working on integrating natural language processing into our machine learning model, as well as evaluating the potential utility of patient-reported outcomes. And then, of course, we are looking into generalizability. And for those interested, this study has been since published in the Journal of Clinical Oncology, and these are the citations for both the machine learning model as well as the clinical trial. And thank you for your time. Please feel free to reach out to me with any questions.